Welcome back to the summit. My name is Dr. Jack Powell III. We've really enjoyed having you view our shows over the last year or two that we've had these. Today we're going to try to show you how a total knee is performed. We had a previous show where we went through talking about how do you get ready for a total knee, what patients need total knees. And today we're going to show you some of the mechanics of it. We thought we'd show you a model because the surgery itself gets kind of bloody, and we thought that'd be the best way to start out with this. So we're going to have a model here today. I'm very thankful to have Zane McDaniel, who from Depew works with us. He's in the operating with us, helping us with equipment when we do a total knee. Also, we have Marcus Jeter. He's one of our fine assistants that helps us in the operating room as far as handing us the instruments and things. He's been with us quite a few years, and he does a wonderful job, as all our scrub techs do. As I said earlier, this is a technique that takes a team, and it takes a while to get your team together, and thank goodness we've got people like Marcus and Zane and Walter Clark and others that have been with us for years that really understand the procedure and have taken a really interest in doing it. First of all, what I'm going to do is just show you, these are the type components that we're putting in. There are many types of components. The one I like to use is called, it's made by Depew, which Zane's company makes. There are other companies that make these too, but this is a process that's been around a real long time and does have evidence of longevity, where I mean once you put it in, it will last a long time. And we have studies going up to 95% good results at 20 years. So we think that this is a very good component. Of course, it has been modified over the years, and things have improved with the development of the techniques over the years. And this is the femoral component. We'll show you, we'll do the cuts. It actually fits here, and we'll make cuts to fit this component on there. And we have all different sizes. They go from about 1 to 6. And then we have a tibial component, which sits here, which will make cuts, so this will fit in there too, so it'll fit very nicely on the bone. And we make our cuts, and here, these are really the ligaments are much more complicated than these two strings, but we will do techniques to balance the knee after we get in there to make sure the alignment of the leg, if a patient comes in with knock-kneed or bow-leggedness, we can correct those by doing ligament releases and making bone cuts. Today you won't be able to see that as much because we're just going to be doing on this model. One other thing about the knee is these models are more difficult than actual bone because they don't cut nice as quite as smoothly as bones. This model can be very difficult at times. The other thing is this is all the final result we're going for, and you can see as this fits here, this is the bone called the femur. This is your kneecap right here, and then this is your tibia right here. And as I showed you earlier, the femoral component will fit here. The tibial component will go here, and you can see it has little flanges on it and things that help it fit into the bone, and we do cement all these components. And then of course you've got the kneecap, of which we'll make a flat surface on that, and we actually put a plastic patella in there. Today we'll show you that technique with the device we use to make that cut. At this time I think it's time to go and get started. And Zane, do you have any questions or do you want to ask any concerns before we start?
As we get started, I'll just mention a couple of things because obviously this is a very scary operation for patients. A lot of patients have only had childbirth for the females, or many men have never had an operation. And so I'm really proud of the team at the hospitals that you work at. They take great care with those patients to reassure them. They're scared. And it is a big operation, but a lot of things, a lot of planning have gone to help today's operation come about for the patients. And one of the things I'm really proud of is the way you take care and reassure those patients.
Well, thank you, Zane. And I think we'll go ahead and get started. So the first thing we're going to do, Marcus is going to hand me a reamer that we use. We're going to make a cut, or actually a hole right up the middle of the femoral canal to put our first component in. That's good. All right, that's there. Thanks. We usually have a device that sits down the middle of the canal, but we're just going to use a drill to put this first cutting device on. That's good, that's there. That's pretty good now. I think I've got it. Good, okay.
Some patients think that you just cut the end of the femur off, but indeed, as we talked in the earlier session, you're just cutting thin slivers of bone off. Is that correct?
We do, and we take certain amounts depending so we can get the knee balanced right. We normally take about 12 millimeters off the distal end, the tip of the end of the femur there, and it's going to be a nice perpendicular cut as you'll see here. But first of all, I'm going to drill to put hold this cutting jig in place. Thank you, Zane.
Yes, sir.
That's good. There we go. I'm going to switch places with Zane here to bring this saw in here to cut it with. Saw right here. This is just an oscillating saw that we use, and you can see that we've got a little edge that we basically go through to make the cut perpendicular. Sometimes I have to flip the saw around so I can get the blade all the way down. As you can see here, we've got a pretty nice smooth cut, and I always take a flat surface to make sure I've got it just like I want it to is. Sometimes I'll go back and recorrect that. So now we've got the distal femoral cut. That's the beginning of the operation. Well, there we sort of build around that initial cut to get the other cuts that we need. This jig right here helps us make, we call it the chamfer cuts. This device measures about a 2.5, of which this bone is basically made for that. And then we'll go ahead and take some, is this a right knee or left?
This is a left.
Left knee. Of course, I can't tell which leg it is by the, because we don't have the rest of the body. We just got this one limb standing here. Let me have 2 pens, please. Thank you. Left medial, left lateral. And I made 2 little holes there to put this next cutting jig in place. There you go, Marcus.
Dr. Powell, sometimes the patient's leg will not straighten out. Is that a goal of the surgery to both?
We do. It depends. A lot of times I have a flex. We call that a flexion contracture, Zane, and basically that's where the knee doesn't come out to full extension. So what we do is we make cuts and do ligament and balance the ligaments so we can eventually get the leg out straight when we finish the operation. Patients don't do well when you don't have the leg out straight because they tend to walk with a flex position. They can't motor around like they need to.
So your goal at the operation is to have it straight from the front and
straight from the front,
side.
and get as much flexion extension as we can. Can you hold that for me while I hold that there? So okay. I'm cutting the back side. Got to get those ligaments. You can pull it out, baby. Let's see here. Can you hold that, get a little track of this, I won't cut it. Well, what I'm having Zane do is protect the ligament on that inside. And those are the cuts on the front and the back side of the femur. Now I'm going to make some cut called chamfer cuts. So that's where the prosthesis will have a mold to fit onto. Is it on good? Good. As you can see here, now we'll take another little device. We'll try to trim these up to get them exactly the way I want them. You got the other little
chamfer
piece? Yeah, chamfer cuts. This is another little piece we usually use just to make sure we get them cut exactly the way we want them. Make sure I have it good and smooth. As you see, we want a very smooth surface for that to fit on. And these cuts does that, and I think we'll see now the prosthesis will fit pretty easily there.
So again, Dr. Powell, you've just cut the edges of the bone off that are the same thickness as the implant that you're going to put on there.
Correct. And this is a 2.5. This is actually between the size 2 and 3 that we're using here. And let's hold the leg like that. Let's see. There we go. As you can see here, this fits pretty smoothly. And actually, I said at the time of operation, sometimes it's easier to actually, bones are easier to cut than this, but I'm pretty happy with the way this looks. And basically what we'll do is use cement to hold that in place. So the next step of the operation, after we've gotten the femur prepared, is we go down to the tibia, which is the lower bone, which I showed you a minute ago. And what we plan to do here is we have a jig for that too, to make sure we have the right alignment, because it's very important to have this cut perpendicular to the floor. And of course the tibia does tend to slope a little bit posteriorly, so when we put the jig on, we'll make it so we do cut a little posterior angulation when we cut front to back. And this is a jig right here. And moving this piece this way, front and back, I can sort of control the angle that I'm going to use for the cut of the tibia. And we have this little guide here that basically tells us how much tibia we're cutting off, so I can go to the low point of the tibia here and use this jig here to help me make sure I'm cutting just the right amount of bone off to make sure we get enough, because we do want to get the leg out straight. Sometimes we have to go back and take another cut because we didn't cut enough initially. Got some pins there, Marcus.
Drills there.
Yeah. What I do is use a drill here to put this in place. Got a pin?
Mm-hmm.
Yeah, slip that in there, Marcus. Good deal. And we'll use do the other on this side. So we have our template now to put the next template on. There we go. This is good. And we'll just pull this off here. Good.
So all of these instruments have really made this a very technical operation to get it precisely aligned, right?
It has, and they basically, what's happened, these instruments over the years have improved, so we actually can cut better, and also we've varied our type saws that we use, and things work much smoother now, and we get much more precise cuts. So I'm just going to track those ligaments, because this part of the operation we can actually cut the ligaments. These two strings of what we represent as a ligament. Cut, we're not taking off quite as much of the tibia as I'd like to do, so what I'm going to do is advance it down a little bit. I've got some other holes that I can use to advance it, so I'm going to advance it down to take a little bit more of the tibia, as you'll see here.
Now, Dr. Powell, the patient is usually asleep during this, so they don't hear all this?
We do. I do most of my surgery on the spinals. I don't like to put people to sleep if we can. We basically deaden their legs up, but what we do is give them IV sedation, so during the procedure, it really doesn't, they don't hear anything, and they really don't even know what's going on.
They're
so
very
it works
drowsy.
Very drowsy, and it works very well. So you can see here, as you look at this cut, this is pretty much perpendicular to the floor. If you look at it close, it does have a little posterior tilt, which a normal tibia does. So we basically have done the tibia cut, the femoral cut, and what we have a little jig here that we use to actually get the tibia in place. Nice. I'm going to take these pins out.
So now you have a nice, pristine, smooth surface.
We do.
That has no nerves, so that the knee has hurt because of the pain once the cartilage is worn away. Is that the indication?
Well, that's it. Where you get bone on bone, or as I said earlier in the earlier segment, we don't really, I really don't do total joints until the patient comes to me saying, "Doctor, my leg's killing me. I can't enjoy life anymore, and I'm willing to accept a few small risks of surgery to get my leg fixed." It's like life is no fun living anymore. So that's when we go ahead and proceed with a total joint. Now, occasionally I have a patient with, like in a knee, they have such deformity, I sort of suggest to them that it'd be a lot easier to go ahead and get the knee done now than waiting where we have to sort of change the technique, and the technique gets more difficult as the deformity gets worse. But normally I let the patient make that decision, which I think is the best way to go, because I've got a lot of people walking around bad looking x-rays that are very happy and they're still living their life. So it comes down to the point, if life's no fun living, and life's just really a chore because of your painful arthritis, then I think it's time to suggest maybe a total knee or some other surgical procedure.
Is night pain a big indicator of that?
Night pain's a big indicator. just affect, when they can't get out into their general lifestyle and they're just frustrated and they hurt all the time. Can't drive to the grocery store and those type things.
Yes, sir.
So what we're going to do next here is we have different sizes. You can see this is one of the tibial measuring guides we use to actually make the component that fits on the tibia. And these come in all different sizes, but this is like a 2.5, like I said earlier. And we can go from like 2 all the way to 6 and even bigger if we have to. So what we plan to do here is I'm just going to basically put this in place so we can make our cuts on this, and I'll show you how this works.
So actually you're fitting the implant to the patient's bone.
We are.
Now, a minute ago you discussed using cement. Is cement sticky?
The cement is sticky, and there are people trying to do these without cement, but unfortunately the studies have shown that with cement they have just as long longevity and actually do just as well. And there's some issues with the bone growing into the prosthesis or the total knee, especially on this surface here. When you've got a flat surface, it's difficult to get the bone to grow into that surface. Now we do total hips where we basically implant everything without cement. So I use cement when I think it's indicated, and then don't use it when I think I can get when the studies show and I found that you really don't need it.
But you make that decision based on a number of factors: patient's activity, patient's
Absolutely.
age.
Thank you, Marcus. And what I'm going to do here is basically just go down the middle of the tibia to put a hole so we'll have something to put the component in. Then that piece flips off, then we have another jig that we're going to make a little triangle like I showed you earlier.
So that the hole you just made is for this portion of the component.
Right. And then the next hole we're going to make, as you can see, it's got 2 phalanges that come out here, and we're going to use a little device to make the hole for the phalanges to fit in. Do we have that?
That piece we're going to take the hole out of, yes.
Oh, yeah. I'll get it on there. Okay. And as you can see, this sort of matches up to that. And we just basically put this in here and just knock it down in place like so. And we take this off here.
And then for today's purposes, we'll pull this off and put just the plastic in, and you can reduce the knee.
Yeah, we have a trial. What we do next, after we get all the cuts made, of course we do the patella is the last component we do. And on the patella, what we do is we have a device that cuts a patella, and it basically cuts a perpendicular surface for us. And I'm going to let Zane hold the femur and I'll hold the tibia. And the patella sits like this. And this device, we have the patella flipped out of the way to get to the surgery. And what this device does is sit on top of the patella, and it uses the underside to sort of get the undersurface of the patella. And then we take a saw. As you can see here, we have another little jig. We just sit the saw right down in here, and we cut a perpendicular surface on the patella. So therefore, after we cut that, then we have a little jig that we make some holes, and we cement the patella in place.
So once again, it's just removing a thin layer that is replaced by a synthetic covering over the edge of the patella.
Correct.
Like this.
Thank you, Marcus. And as you can see, once you get it in place, you just have a little 3 little holes that we cement in place onto the bone, and then it works very nicely. So it's just the patella is not on this model that we're using. So what we're going to do is put the femur in, put the tibia in, sort of show you how that works, and then we'll proceed from there. And as I said before, we do trials. What we'll do is we'll do a trial of this knee first, and we'll make sure everything's perfect for us fitting. We're happy with the ligaments, happy with the patella. And then we proceed with proceed with high pulse lavage, where we use a high pulse fluid to basically make holes to free it, get all the blood and all the debris out of the bone so the prosthesis will fit down on there. Once we get that, then we go ahead and prepare the cement, put the cement in place, and then put all components in place. And it takes about 7 minutes for the cement to dry. Then after the cement's dried, then we go ahead and let the tourniquet down, check for bleeding, and then close the wound up. And here's a femoral component that I'm fitting in place right here.
So that using these trials lets you know before you open the packages
Exactly what we're going to use. And we have the ligaments. We can check the whole knee before we even open the packages for the permanent components. Because we have like 6 different sizes for both the femur and the tibia. So we don't want to open up 6 sterile packages of different components. So this way we can tell exactly what we need before we proceed. As you can see here, we also have different size tibia plastic that we can put in. These go from different millimeters to thickness. So if we need a thicker component, we can do that before we do the procedure. We put the final components in. And as you see here, this fits very nicely in here. Of course, it's a little more difficult with the way the ligaments are, but you can see how the knee goes backwards as extension and here's flexion. And we were talking about earlier, we like to try to make sure we have the knee out in full extension because the patients don't ambulate well if they don't. We like to have that at the table. And of course, the kneecap's on top here too, so we can also check the position of the kneecap to make sure it's stable. And in some positions, sometimes the kneecap will pop out on us, so we have to do some ligament releases to get that in position so it won't give us any further trouble. Let's move that one more time so they can sort of see.
So you run that through a range of motion, bending it to be sure it bends and straightens. Before you stop and put the final components in.
Correct. And then we prepare the femur and the tibia like you saw me earlier, and then we have the permanent components that fit in these different holes that I showed you with cement to hold everything in place.
Dr. Powell, one of the things that I brought today for the viewers, we have a lot of instruments that have been on the table here. Marcus has assisted with those, but I think I've told you before, there's a very famous surgeon in Atlanta, Dr. Jim Funk, that some of the patients may have used before. These are some of his instruments. I was very fortunate to work with him. And so everything was made. You made the marks on the femur with that. You align this with the tibia. You cut off the anterior with that. So you've come a long way in the instruments that you use to make it very accurate.
Absolutely. And I can remember back many years ago when I first started Grady and Emory, we, in some of my fellowships, I mean, we were not scoping knees in. And we were actually looking through a little hole in a scope, sitting up there at the knee trying to see in. And now we do it all camera and TV, so it's very easy to see. So things have drastically improved, as I can see here, and thank goodness they have.
I just wanted to bring these because I knew you hadn't seen them before, and I knew
classic.
Bring a chuckle. We're about out of time. I thank you very much for the opportunity to work with you. We take this business very serious, and I'm proud of the friendship we've had and the longevity, 25 years that we've worked together.
It's been a lot of fun, and only one other thing I want to say is the post-op care. Once the knee is done, of course, the post-op care is very important. And we're usually in the hospital 3 or 4 days after surgery. Some people are trying to do them as outpatients, but we're headed in that direction too eventually, I think, as long as the patient's healthy. And of course, they'll be put on some type of blood thinner to prevent blood clots, which is a real issue with total knees, which we do everything to prevent. And then they start a rehab program really the day or the day after surgery's done. And we'll have them walking on their knee within a day or two of the surgery. And then the big thing is getting the flexion, the part we talked about, getting the extension and the flexion. And the rehab takes sometimes up to 8 weeks to 3 months to get the motion. The surgery is easy for me. The hardest part is for the patient to get their motion back. And they spend a lot of time working on that. And we have a very strong rehab program under the direction of Dr. Russ Foley, who I think in another segment we're actually going to pick a patient that had a total knee and go through the rehab and show you how we proceed with that. So again, I'd like to thank you all for viewing with us tonight and having fun trying to do this. I hope this helped you some. This was a little more different than actually doing it at the time, doing it in the operating room, but at least it gave you an idea of the instruments and things we use to complete this procedure.